A lot of people have.
Good evening, friends. Good evening and welcome to this international webinar at Believers Church Medical College and Hospital. Kindly excuse the mask with the COVID situation. I'm forced to not remove the mask because more than one person is there in the Zoom room right now with us. So it's a great honor and it's a great privilege to have in our midst a very distinguished faculty, and he will be introduced by the moderator for the day, and the moderator is none other than the senior consultant in endocrinology at Believers Church Medical.
Somebody.
Radha and Ruby, please mute.
Dear friends, there's a lot of
Yeah, they muted. Yeah, go ahead.
1 second, sir. Okay, sorry for the interruption, and it's this particular webinar is really a high-profile webinar. We have an amazing speaker, and he is going to be introduced by none other than the senior consultant of endocrinology at Believers Church Medical College and Hospital, Dr. Philip Finney. Dr. Philip Finney himself is a distinguished endocrinologist. He has trained all his life, right from undergraduate, postgraduate, and super specialization at the prestigious CMC Vellore. He's been path-breaking in a lot of research work, and also he's been at the mission field, serving to the rural people for the last decade. So he is currently heading the endocrinology department, and he's great, compassionate doctor and also an erudite scholar. So let me welcome Dr. Philip Finney to moderate the session and also to introduce the speaker and hand over the session to him. Over to you, Dr. Philip Finney.
Good evening. Am I audible?
Yes.
Yes. Good evening to all of you, especially a special welcome to Dr. V. Mohan. It's such a pleasure to have listened to him a few months ago on the Believers webinar when we had a good talk on clinical inertia among clinicians, especially when we manage diabetes. And it was a joy to listen to Dr. Mohan, and it's such a joy to have him back today discussing such an important topic of precision diabetes. Last evening, in preparation for the talk, I was listening to Matt Might, a gentleman in the US who talks about precision medicine and how medicine has evolved from the 1950s to 80s when we used to have intuitive medicine. Then we moved into the era from the 80s to 2000s of evidence-based medicine. And now we're moving into personalized of precision medicine. And it is such a useful topic for us to discuss today, because diabetics are not just one basket of patients. There's so much of differences among these patients. And if you actually look at the newer classifications of diabetes in the Lancet, which have come a few years ago, now diabetes is classified into 5 major groups based on the phenotype, the genotypes, and so many other things about insulin resistance. And I'm not going to tell anything more because Dr. Mohan will be talking about that, I'm sure, in the coming talk. So I just want to welcome all of you who have taken the time to be here. I just want to say a couple of words about Dr. Mohan's CV. Is so long. I think I can speak for 1 hour on Dr. Mohan's CV, but I'm going to cut it short in a few minutes. Dr. Mohan is the chairman and the chief of the diabetology services at the Mohan's Diabetes Specialty Center at Chennai. And he's also been awardee of the Padma Shri by the Government of India for recognition for this excellent contribution in the field of diabetes in 2012. He's also received the B.C. Roy National Award. He's a fellow of the Royal Society of Edinburgh, which very few Indian doctors have received this award. He's also done his MD, PhD, and he's got a number of fellowships, more than 180 awards. I was just going through the CV. Dr. Mohan has published more than 1,300 research articles, of which the majority of them are original articles, and many invited editorials and review articles are there as well. It has been such a joy to have listened to Dr. Mohan when I was an undergraduate at Velo, as well as a postgraduate. And it's such a joy today to have the privilege to share a platform with Dr. Mohan. I consider it a great privilege. And I'm sure all of you will really benefit from this talk. And I request you all to pay a full attention as Dr. Mohan unpacks this talk for us. Thank you so much, Dr. Mohan, for being with us. It's our joy to have you, and I really look forward to listening to you. And at the end of this talk, I'm sure he will be happy to take some questions, and we'll try to make this session most useful for all of us. Welcome, everybody, once again, and I look forward, and I hand over this time to Dr. Mohan. Thank you.
Thank you so much, Dr. Philip Finney. Let me just get my slides so that I'll be set after that. Are you able to see the slides?
Yes.
I'll make it full screen. Yeah. So, Dr. Philip, I also look back with nostalgia, and it's not often that within few months one gets back to an institution and gives a second talk. I don't think that's happened in the last few years in any of the colleges or institutions or any other thing where I gave talks. It's usually been one, and then the cycle goes and many others then invite. But this shows a love and affection. Of course, I must mention Dr. Jacob Jesuran, who's so persistent and so much love and affection he shows, and you too. And the entire last time I really enjoyed my interactions with you, and that's why you won't believe it. Tomorrow I've got a very big event, and I'll talk about that. And the end of this month we have our update coming. It is our biggest event. It's several thousand people attend. So in the midst of all that, to accept an invitation like this is rather unusual, but it's only because it came from you all that I accepted. Many others I have said no. So on that note, yes, I'm going to talk about precision diabetes in India, and I'm aware that my team, Dr. Radha Venkatesan, whose name you see there, she's the head of genomics and plays a very important role in precision diabetes. In fact, in the beginning itself, I must tell you that what I'm presenting today is mostly published data, of course, published from our own work. But just yesterday, she showed me some very, very exciting data, which she's going to present at the update at our conference 2 weeks from now. And she showed me, in fact, there's an ICMR meeting on Monday morning to review our ICMR Advanced Center work. And there also she's going to present. And I was quite excited by what I saw. And but I won't be able to show that today because it's still raw data and it's being processed. But once that is done, and I'm sure it'll also get published and also get presented 2 weeks later at our conference, it's really cutting edge. And for me, having been for 50 years in this field, it's really, really satisfying because this is really cutting edge. And not only that, not only cutting edge research, it's changing the lives of people. But today's talk also, I hope a flavor of that I can give you. What Radha's now got is going beyond that to the next stage. But today's work itself will give you a flavor of what I'm trying to say. I'm sorry, Dr. Philip Finney, I didn't have your photo. I had made these slides a week or two ago, and I didn't know that you were moderating. So I put only Jacob's picture. I wish I could have put up your picture as well. And once again, thanks to both to you and to Dr. Jacob Jesuran and all the people who are organizing this meeting and all the attendees as well. I have no conflict of interest to declare. Most of the funding has come from the Indian Institute in the Indian Council of Medical Research, because we are an ICMR Advanced Center for many years now, thanks to the work of Radha and her team. And then, of course, some of the work has been funded by the NIHR, the National Institute of Health Research in the UK. So these are the two funding agencies. Now, when you talk about precision medicine in diabetes, I'm very much part of an initiative from the US, particularly by the American Diabetes Association. It's called Precision Medicine Diabetes Initiative. It's actually Precision Diabetes Medicine Initiative, PDMI. And there are a lot of people in the world who are working on this. In fact, I formed a whole team of about 200 scientists who are going to work on this. And I'm very privileged to belong to the core committee in that, and also the only one representing India on that. And in that, what we have done is we have divided precision diabetes into precision diagnostics, precision therapeutics, precision prognostics, precision monitoring. So it's been divided like that into different precision prevention. So 5 different domains. And one of those areas, Dr. Bodhini, who works with Radha and me, we are in that representing the group on precision prevention of type 2 diabetes. But there are similar groups working on each of these. There is a group for type 1 diabetes, a group for type 2 diabetes. Each of these has these 5 subdomains, and there's one on monogenic diabetes. Now recently added one on gestational diabetes as well. So you can imagine how many people are working in the width of that, and we'll be writing several papers on this. Today I'll make it very simple, more from a clinician's point of view. Type 1 I'm not even touching here. So I'll talk about type 2 diabetes, and I'll show you some work that we have recently published on the clustering of diabetes in Indians. And then I'll talk about the monogenic diabetes, and this is where really precision medicine has come to the diabetes clinic, and we are now practicing it day in and day out. And that is in maturity onset diabetes of the young, MODY, and neonatal diabetes with onset of diabetes below 6 months of age. And I'm sure that your alma mater, CMC Vellore, is also working a lot on this, and my good friend Dr. Nihal Thomas is also working on these aspects as well, particularly on MODY. So let me first talk about clustering of diabetes. Now, when we divide, if you take a macro picture and divide diabetes into major subtypes, not even into sub-classification. So you have type 1 diabetes, and you have type 2 diabetes, then you have GDM, and then other types. In the other types, you have about 20 different types. So that's all lumped under other types. That's the current ADA classification of diabetes. The WHO classification is very similar, but slightly different. So these are the 4 types. But then type 1 diabetes is treated as if it's one disease, and type 2 diabetes is treated as if it's one disease. And particularly in relation to type 2 diabetes, we all know that it's very, very different. And this landmark paper from Leif Group's group from Sweden showed that, from Scandinavia, showed that for the first time, and this was published sometime in March 2018 in Lancet Diabetes, where they showed that diabetes could be, in adults, could be divided into 5 types. They didn't call it type 2 diabetes because they included one other type, which I would call as type 1 diabetes, and that is LADA. But they used what is called as the K-means and the hierarchical clustering. It's a kind of a mathematical modeling, a little bit of AI also introduced into it. And then based on that, in a sample size of about 9,000 people from Sweden, they were able to divide into six different types. What are the variables which were used? Simple things: age at diagnosis, body mass index, HbA1c, and then they use, of course, they used also GAD, and I'll talk about that in a minute. GAD antibodies, that is mainly to divide the LADA type from the type 2 diabetes, a latent autoimmune diabetes of adults, which is mainly a type 1 type of diabetes. And then there were 2 things added, one for estimation of the beta cell function, where the HOMA beta was used, and the other to calculate insulin resistance, and there the HOMA insulin resistance was used. Both these are dependent on the fasting insulin. So based on the fasting insulin and the glucose level, this is from Oxford, you have these HOMA models, and you can calculate beta cell function and insulin resistance fairly well. There are 3 independent cohorts in which the replication was done. And based on this, they came up with these 5 different clusters, and many of you would have read this paper. So there are 5 types, of which straight away I can tell you, if I can get that pointer, there's a pointer. 4 of these types, 1, 2, 3, and 4, are type 2 diabetes, and I'll come to that. The first one, as I said, is not really type 2 diabetes. They've used GAD antibodies, and they said if GAD antibody is present, then they called it a severe autoimmune diabetes. Now, generally, we know if the GAD antibodies are present, we call it as type 1 diabetes if it's in children. And if it's in adults, we used to call it not type 1, but we used to call it as LADA, latent autoimmune diabetes of adults. So this is nothing but LADA. It's a severe autoimmune form of diabetes. It comes in adults, very lean, they have insulin deficiency and early onset diabetes in their 30s or 35, 40 years, you get that. And then GAD is positive. So this is the most important thing, GAD is positive. So to me, this is not really what we are talking about. That's a different form of insulin-dependent diabetes, which we really don't need in the classification, that we can take it separately. But these 4 were of interest to us. This is type 2 diabetes. these two, if you contrast, one is a severe insulin deficient diabetes, very similar to the SAID variety, the autoimmune variety, except that GAD antibody is by definition absent, and therefore it's not LADA. The GAD antibody is negative, but otherwise it's a lean person, thin person, low BMI, insulin deficiency being the main thing. The other end of the spectrum is an obese person who has severe insulin resistant diabetes. So BMI is high, insulin resistance is there. So not much of insulin secretory defect. We measure the insulin actually could be high. And therefore the main pathophysiology here is insulin resistance. And here the main pathophysiology is insulin deficiency. So they call it as SID and SIRD. The third variety is what's called as mild obesity related diabetes, or MOD or MOD. This has obesity but no insulin resistance. They don't have metabolic syndrome. You know that some obese people don't have high triglycerides, low HDL. They somehow seem to have a healthy type of obesity. So this is called as a mild obesity related diabetes. The last one is very easy. It's a mild age related one. So if you get it at old age, you get a milder form of diabetes, age related diabetes, and that's called MART. So let's focus on these four: SID, insulin deficiency; SIRD, insulin resistance; mild obesity without insulin resistance; and the age related one. So these are the four subtypes. So then people say, once they said this, everybody wanted to replicate. Is it the same in our country also? And many countries came forward with that. So we asked the question, can we, so it's been replicated in China, it's been replicated to some extent in Portugal with some differences. In Mexico, they found some differences. In US, they had similar to this because they're also Caucasian. So there were mixed responses to that. Basically, some types were replicated and some types were not. Now, why did we want to use this in an Asian Indian population? Is it because we have Me Too research, or they did it, so we have to do it? Okay, they did it in Chennai, now we'll do it in Bangalore. Now they did it in Bangalore, now we'll do it in Kerala somewhere. If they did it in Trivandrum, we'll do it in Calicut. It's not like that. We believe that our Asian Indian population with type 2 diabetes is very different. I'm sure Dr. Philip Finney will agree with that. We are completely different as far as the Caucasian population is concerned. This is not new. We've known this for the last 30 years, that there are so many differences in type 2 diabetes. Type 1, I'm not very sure. But type 2, there are a lot of differences from the Caucasian. Shown here are just 13 of those differences. Okay, there are more, just 13. And I won't tell you all these. There's not a talk on difference between Indians and from Caucasian, but just to tell you why we have to do it. First of all, lower age at onset. Their mean type 2 diabetes itself comes at 50, 60 years. Okay, we get it at 30. Now we start getting at 20 also. So it's much lower. 30, 40 is our mean age at diagnosis. So when you get something 20 years earlier, and you're talking about MARD and all that, it'll all change. Second, they have very obese people. Now, we are also beginning to get very obese people. But for the last 20, 30 years, we didn't have much of obesity. So despite not having obesity, we're getting a lot of type 2 diabetes. Now, why is that? It's something which we have been researching on for years and years. A lot of references here at the bottom, different groups from India and abroad have worked on this. We were the first to show high insulin levels and insulin resistance. When I say we, it was me. When I was working in the UK in 1984-85, when I was working there, for the first time, we compared Caucasians and Indians and matched them at the Hammersmith Hospital. And we showed that Indians had much higher insulin level. And then we did clamp studies and proved that they have a higher insulin resistance. So that came out as a very strong fact, as published in Diabetologia. And subsequently, that's been reproduced by at least 20 different groups. More recently, we found that there's a rapid decline in beta cell function. We don't, the way we lose beta cell function in our type 2s, other groups are not seeing that. We are already having little lower beta cell function, and then it's going down very rapidly, probably because of genetic, because of our rice diet. I don't know what it is. This one is the most important factor, and I'm going to talk about number 5 because we have used this in our studies. Now we have, if you ask me of all this, which is the most characteristic, I would say it's number 5. We have the lowest HDL cholesterol. I've been studying this for the last 30, 40 years now. I have not seen anyone with such low HDL cholesterols. In fact, of all of you who are listening to this talk, I can bet you that 80% of you have a low HDL cholesterol. Without even testing you, I can tell you that. Exceptionally, due to some genetic variation, you may have a normal HDL or a high HDL. Otherwise, everybody has low HDL as an Indian trait. Okay. Why it is so? Radha and colleagues have been studying this for the last 20 years. We found some genetic differences, but I think it's largely driven by the high carbohydrate diet that we take. Triglycerides go up and then your HDL goes down. So that is it. And you can go on and on. Low adiponectin and high CRP, NAFLD is more, low vitamin B12, the thing being a gut microbiota. We just published our results, Indo-Danish comparison. The gut microbiota is so different in Indians and Danish that if you just show me the gut microbiota, I can tell you who's an Indian and who's a Danish. It's completely different. There's no overlap even. You know, Indians are here and the Danish are there, you know, as far as gut microbiota is concerned. It's so striking. Your 2 papers back to back in genome medicine, which you have published. It's amazing, the difference in gut microbiota. So with all this, so many differences, we said, you know, when somebody talks about MOD and this and that and all that, and we're talking about some insulin deficiency and all, we better replicate this. So we got into it. And this is a collaborative study, as I said, was funded by the National Institute of Health Research, NIHR. The study is called INSPIRE. INSPIRE stands for India-Scotland Partnership for Precision Medicine and Diabetes. This is how we set up our precision medicine department about 6 or 8 years ago at our center. We are one of the first to set it up. And as part of this, INSPIRE is a very big project. And this is one small part of what I'm presenting today, a very small part of the INSPIRE collaboration. So first, let me see what you know, the Scandinavian group showed, and then what we showed. First, what we did was we didn't attempt to do anything else. We said, okay, Leaf Group and others have done it. We will use the same thing, the same 6 variables, the same thing that they have used. We won't use anything Indian, and let's see what happens. Now, as far as the Scandinavian group is concerned, it's perfect for them. It is a perfect fit. I'll show you why it's a perfect fit. Now, where would you expect the insulin to be the lowest, the insulin secretion to be lowest? Obviously in the SID, isn't it? Look at that, it's 47. Look at the others, 150, 95, 86. Beautiful, no doubt. Where will you expect it to be the highest? And where will you expect the, you know, the insulin resistance HOMA to be the highest? SIRD, obviously, isn't it? Look at that, 5.5 compared to 3.2, 3.4, 2.6. Perfect, there's no doubt about it, it's perfect. Look at age, 56 in the first group, 65 in the second group, 46, 8 in the third group, and 67 in the fourth group. Again, MOD beautifully fitting in there. BMI, everything fitting in. So there's, I have no doubt at all, there's 100%, 100 or 100 correct. Problem comes when you try to, you know, fit it into our population. This is what we did. We tried to fit it. Look at it now. Now the which should have the highest HOMA beta. It should be the SID, isn't it? With this, look at that. No, sorry, which should have the lowest one. It should be there. For us, it was all over the place. Our highest came not in the SIRD variety, but in the MOD variety. Okay, look at their MOD is 86 and this is 150. Look at ours, 150 is in the MOD group, completely gone. Okay, look at HOMA IR, again the MOD is showing the second highest. You can, okay, look at the age group. This is the most interesting. I told you their ages, 56, 65, 48 and 67. You know what our MOD is? The older one, it is 50 years. That's almost like their other lower groups, you know, completely gone. The age group is completely gone. Look at our group, 41, 44, 48. So we are talking about a 2-year difference between the MARD and the MOD and so on. Okay. So we tried many iterations of the, look at the SIRD variety. They had the lowest HDL, the lowest HbA1c in that, the SIRD variety, 7.1. Look at ours, 9.8. It's the second highest of all. Okay, so finally, after many iterations, we tried with the Danish, with the Scottish collaborators, and finally we said, you know what, this is not fitting in because this is not our clinical profile. So we have to start afresh. We cannot use the characteristics that they used. Then I suggested, and in fact my daughter suggested, Dr. Anjana, she's the first author of this paper. We suggested, why not include HDL and triglyceride? Because that is our characteristic. The low HDL is the characteristic of the Asian Indian. Let's introduce it and see what happens. So we went ahead, and where did we get our patient base from? As you know, we have centers all over India, and we have a very large number of patients, 500,000 patients. So what we did was we used the same criteria that they used. New onset cases who had not been treated, in whom we had all the parameters, and so we had actually much more numbers than them. They had only 8,000. We had close to 20,000 people. So the very line, look at the age distribution. We are not taken only young people. We've taken old people also, even up to 97 years we've taken, so that we shouldn't miss MARD and so on. So we've taken everyone, and then we said, okay, now let's see what we are going to do. Now, we took some of the variables were the same: age, BMI, HbA1c, waist. Now see what we've done. We have included HDL cholesterol and triglyceride because we believe that this is the most important characteristic. I'm firmly convinced about that. Now, we had HOMA beta and we had HOMA IR because the research sample, we had it. But we said, you know, when you start replicating it in India, now, for example, in the Believers Hospital, if you want to do it, where will you have, you know, HOMA beta and HOMA IR and everyone? So I said, you know, something which is a little simpler, which many people have, is C-peptide. Again, everyone may not have it, and I'll talk about that, but we have in almost everyone. So we said, okay, let's use fasting C-peptide and stimulate, because this is something which we have standardized for the last 30 years, at least about 50 to 80 papers are there on this. So we said, let's use this. We use more than HOMA beta and HOMA IR. So let us use this. So these were the eight variables that we used. What did we find? What we found was, as far as SID is concerned, we were able to tick the box. Yes, we were also able to find SID. Early onset diabetes, low BMI, waist was low HOMA beta, low HOMA IR because less insulin secretion, less the insulin resistance also therefore less, and low C-peptide. Obviously, that's what we measured. Now, they had what is called as SIRD. We found a different type of insulin resistance, and it's called insulin resistant obese diabetic, or IROD. I'm not going to what those differences are, but we explained it in the paper, and all the reviewers accepted it. Now, this had obviously the highest insulin resistance, highest BMI, highest waist, and highest C-peptide. So this is the exact opposite of that, except that instead of SIRD, we had IROD. So this is a novel subtype which we described in India. But the biggest difference was the third one. Now, remember, they had an insulin deficient one, they had an insulin resistant one, and then they had mild obesity without insulin resistance. We had a third where we didn't have that mod at all in our group. It's not there at all. Instead, we came up with a third variety, which is called CIRDD. It's a combined insulin resistant and deficient, which, in other words, if you combine SID and IROD together, you get this variety. And that you will all agree with me that some people look obese, but their insulin secretion is not very good. Okay, they still need insulin early and so on. In your practice, you would have seen that. So this has the combined features. And guess what? These people had the lowest HDL. I'll come back to that. They had the lowest HDL and the highest triglyceride of all the four groups. So I told you that is the most characteristic one, and it's the most characteristic in this particular group, and that's why they didn't see it in the West, because this group doesn't exist there at all. And we were able to pick it up, luckily, because we included the HDL in that. And then, of course, the mild age-related variety is there, but it's not as old as the Scandinavian group. And they had the best prognosis, and they were the easiest to treat. Their HbA1c was lowest. I'll show you that in a little greater detail. Now look at it. I told you when we did the first time round with the Swedish parameters, we could not, replicate it. When we used these, it replicated beautifully. For example, if you look, you remember those age at diagnosis I showed you with that one, we are getting similar ones. See, 42, 46, 42, and 50. So our MOD is only 50 years old. They are not 60, 65. India's lifespan itself is only 67 years for males and 69 years for females, whereas their lifespan is 83 years. So that is why this difference we are seeing. We are treating a different population. Now you look at these parameters. Which should have the lowest BMI? Obviously the SID variety. Which should have the highest IROD? Which should have the highest BMI? IROD. Which should have the lowest waist? SID variety. Which will have the highest waist? IROD variety. Okay. Which will have the most, highest HbA1c, worst control? SID variety, because they have insulin deficiency. Which will be the next worst? It should be the third variety, because they have insulin deficiency also. So that has come correct. Okay. Now let's go to the triglycerides. You can see the HDL. You can see the HDL is low in all the groups. So that's a characteristic of Indians. Anybody you study, they have low HDL cholesterol. But within that, see 40, 38. Look at the third variety, it's 36. The mean itself is 36. So that is the lowest. And the highest was in the MOD variety, because they are the healthiest group. They had the best. Now look at the triglycerides. 149 peak here, 155. They had only some 80, 100, something like that. Here, everybody has quite high, 149, 155. Look at the third variety, 351. They are standing apart. completely apart. You cannot miss this group. When you start studying Indians, you cannot miss this group because they're having the highest triglycerides. Okay. And the MOD, of course, had the lowest triglycerides and the best HDL. That's why they are survivors and getting it later. C-peptide, lowest in the SID variety, best in the IROD variety. Stimulated C-peptide, same thing. HOMA beta, we just put it in to show it here. The lowest in the SID variety and the highest in the highest in the IROD variety, and the next lowest is in the SERD variety because they have insulin deficiency also there. So we got a perfect fit here, and then we tried 2-3 replications within our own clinics, and we got it again and again. The same answers came. So we said we are confident about this, although we are now taking on a very big group, a Swedish group, but we still believe that this is true. So we went ahead. So, okay, now comes the next question. A criticism can be, well, it's all from your own clinics. Now, maybe the data is correct, maybe everything is correct, but it could be a biased sample because who comes to your clinics? Maybe the middle class or the upper middle class, or maybe some other rich people also will come. So isn't that a bias? Is that why you are seeing this? And maybe if you took the whole of India or something, or a representative sample, you may get like the Scandinavian one. In other words, can you replicate it in a national sample? Now, we were very lucky because we have the INDIAB study going on. And in the INDIAB study, the whole country, as you know, is being studied. Many of you know about the INDIAB study. I think I talked about it last time also. So the whole country, luckily now we have finished the INDIAB study. And some of you may know that's the largest epidemiological study on diabetes ever done, perhaps in the world, certainly in India. And so in INDIAB, we had these variables. We had age, we had BMI, we had waist, we had HbA1c, we had triglyceride, we had HDL. But we didn't have C-peptide because C-peptide is expensive. So we said, okay, let's try one more experiment now. Okay, we have been experimenting. We have found out those 4 subtypes in INDIAB, and INDIAB, remember, is a representative sample. It has urban, rural, men, women, exact snapshot of India. Now, when we go to INDIAB, we said we'll be a little bit more ambitious. Let's leave out C-peptide now. Okay, but these 5 or 6 will be available in any clinic. Tell me one clinic which doesn't have waist or HbA1c or triglyceride or HDL. So we said, let's just use this and see whether we are lucky or not. Otherwise, we'll have to say, sorry, you have to do C-peptide. First, we'll try this, we said. When we tried it, we were extremely lucky that we got the same 4 types, SID, IROD, SERD, and MOD. I told you about triglyceride and HDL. So look at it. Look at that HDL cholesterol in the Indian sample, 40, 37, even lower than our population, because our population is a little, the socioeconomic state is a little different. Look at India's HDL, 40, 37, 39. But look at SERD, 31. Okay. Look at the triglycerides, higher than what we have in our population, but maybe our patients are treated. So 180, 187, 150, 414 is nowhere in the picture. So exactly same as what we got in our clinic, we got in INDIAB. And these are all newly diagnosed people before they've started treatment in INDIAB, people whom we went and screened. They've taken their samples, everything done in the central lab. And so the results are reliable. Once we got this, we were confident. We said, see, once you replicate in India, we don't have to bother about it. This is an Indian subset. So now the next question comes, what is the clinical relevance of all this? You know, why should you even do all, why bother about what is precision medicine got to do with all this? So we said, okay, let's look at 2 things. Number 1, let's look at complications, whether it makes any difference. And number 2, let's look at the treatment, getting the HbA1c under control. If these 2 things we're able to show some differences, then it's worth it doing this clustering. Now, to be fair to the Scandinavian group, they had shown something that the SID variety, if you have insulin deficiency, you are more prone to retinopathy and neuropathy, but not to nephropathy. If you have got insulin resistance, you are more prone to NAFLD, to cardiovascular disease, and to nephropathy, to diabetic kidney disease. This is what they showed. So resistance goes with those 3, whereas the insulin deficiency goes with retinopathy and neuropathy. So we said, let's look at it in our population. Now remember, we have got different groups now. Okay. Now, what did we find as far as the insulin deficiency is concerned? Absolutely right, what they said. The SID variety had the highest odds ratio. We have taken the MOD as the reference here, by the way. So there's a 56% higher chance of the SID developing retinopathy. The insulin resistant, they said, doesn't associate with retinopathy. Yes, that's true. That doesn't associate. But look at the SERD guy. Now we have got again little insulin deficiency here. Remember, now they are also prone to retinopathy. So what's the moral of the story? Moral of the story is if you have insulin deficiency, you are more prone to retinopathy. Even we have not studied neuropathy here, by the way. We looked at retinopathy, and to even CVD we have not looked at because we didn't have data in INDIAB and so on. But kidney disease we do look at. So remember, which is more prone to nephropathy? It's the insulin resistant group. Is that true? Yes, it is true. Okay. If you look at this now, forget about nephropathy here, microalbumin is included. Look at CKD. CKD, the IROD variety is more prone, whereas the SID was not. It's not reaching statistical significance. See, whereas the IROD variety is more prone. But guess what? The SERD variety is also prone to nephropathy because they have insulin resistance also. So the SERD guys are actually bad guys because they can get both retinopathy and nephropathy, and they have the worst dyslipidemia. So obviously, if you look at cardiovascular disease, these will be the guys who will develop cardiovascular disease faster. And therefore, I think the Scandinavian group was right as far as that was concerned, except that the SERD is a new finding from India. Now let's look at the diabetes control. Now what is shown here is how long does it take to reach HbA1c of less than 7%. Which do you think would have been the easiest to reach? Obviously MOD, the green wallas. You can see that their highest percentage is reaching the HbA1c target of less than 7%. Which is the most difficult? The SID variety, because they've got insulin deficiency. We didn't know that they have insulin deficiency. So how did we treat them? We're treating them with metformin. We're treating them with something using your usual guidelines. And you can see that these blue guys are not reaching the target. Who do you think will be the next most difficult to treat? Obviously the SERD variety, because they also have insulin deficiency. So we found that the red one is the next. And of course, the IROD comes in between. So the most difficult to treat. So in your practice, when you find some people getting to HbA1c target very easily, whereas others are not. Now, I think with reasonable accuracy, we can say they have insulin deficiency, and therefore they probably need a secretagogue to get it under control. And we'll come back to that later. And then we went ahead and okay, I got muted suddenly. So we went ahead and published this, and this has been making quite a lot of waves. There have been a lot of press write-ups about this. And by the way, this has been reproduced by many other groups. Now, okay. So let me leave type 2 diabetes at that. There is more, we're doing much more work on this. We have, collaboration with the Dundee group and Radha and so on. We have been looking at genes and seeing whether the genes play a role in this. And of course, genes play a role. We are not yet ready to publish that, but we're getting ready with that. This is genome-wide studies and the Jivas and so on, which are looking at to find out whether the clustering of one gene makes it like this and other like that. And yes, there are certain differences. The other thing we have done is we have just submitted another paper where we took up an independent study of diabetic clinics all over India, trying to replicate it. And we got a much larger sample size, about 34,000 individuals from about 15 clinics in India. We said, let's try to replicate it. And they all gave their electronic data. And when we tried to replicate it, we got exactly the same replication in that. And there we also tried to retrospectively see whether the sulfonylureas or secretagogues did better in the SID group and metformin did better in the other group. We did get some answers, but the way we treat is we just give like a shotgun approach we treat now. So it is not a clean study. We got some indicators. Based on that, now we're doing a randomized clinical trial. So we start in an RCT where we're going to first classify and then treat according to that. We'll have a control group for each of them. It's a very complicated design, but the study is just started. And we are trying to see whether we can get an RCT to finally prove what drug should be. So now today, we say metformin first. If that doesn't work, you add either sulfonylurea, or add this or add that. That's how we're going. But now what we will suggest probably after that RCT is over is, no, you classify using simple techniques. You can use a small app and say which type of diabetes is sitting in front of you, and then you choose that particular drug. Now, if this is not precision medicine, I'll ask you, what is precision medicine? This is exact precision medicine applied in the clinic. Have we reached there yet? Not yet, but I think within a year or two, we will definitely reach that particular stage, and that's the aim of this. Now, let me move to something which you already reached, and we're already doing in the clinic, and therefore will be very interesting to you, and that is monogenic diabetes. I'll only talk about two. There are about 5-6 types there. We have a lot of exciting data, but I'm not able to show you all of that today. So I'll just talk about MODY and I'll talk about neonatal diabetes. What is MODY? MODY was first, MODY is maturity onset diabetes of the young, first described by Tarisal and Fayance in 1975. When I was in final year, I read that paper. And then what does it, what are the clinical features? They are young people, but they don't need insulin, below 25 years onset. They don't have ketosis. They have no beta cell autoimmunity. They can be controlled without insulin with oral drugs for 5, 10, 15, 20 years also. Impaired insulin secretion is the main thing because beta cell defect is the main thing. There's no obesity, no acanthus nigricans, no insulin resistance. And if you look for a gene, you will find. Somebody, can you mute, please, somebody? Okay. So, so if you look for a gene mutation, you will find it. Now, this is a clinical description. At that time, the genes were not known. The first genes were described by Philip Frogel and others in 1992-93. Since then, we have about 14 different types of MODY, which have been described. This is the gene and this is the locus, the 20th chromosome, 7th chromosome, 12th chromosome. So all over the place, you have these MODY genes. Let me hasten to add that although these 14 types have been described, many of these are not really MODY. And now in a recent reclassification of MODY, many of them have been dropped. For example, 7 and 8 and 9 and I think 11 and I think 14. These are not really MODYs. And the main ones are MODY 1, MODY 2, MODY 3, MODY 5, and probably MODY 12. And MODY 10 is also there. It's extremely rare. We have not seen a single case. But these are probably the 5 accepted MODY types. And they all have their own clinical features. And using clinical criteria itself, you can diagnose them. Now, you may ask, why bother? Why make diabetes so complicated? And why should you bother about this MODY and all that as a clinician? Why don't you just give insulin or tablet or something and be done with it? Now that I would have done if I was a GP. If I didn't know anything about diabetes, I'd probably pick a lottery when you come. Pick this, or a box could you pick. Okay, you pick sulfonylurea. I'll give you sulfonylurea. Okay, or I'll have to go to my Jolson and then say, astrologer, which shall I give this fellow? And then ask him and then treat. I think we have come a long way since then. We are trying to bring science into this. So that is why we should bother about MODY as a clinician, because we shouldn't end up treating them wrongly. And to illustrate that, let me give you this particular example, true case story. 16-year-old girl, about 10, 12 years ago, she came to us. She was thin, presented with severe diabetes. 16 years, thin, presented with severe diabetes, HbA1c 10.4. Straight away, you'll say it's type 1, isn't it? This is type 1. What else is it? Now, because of the young age at onset, she had been actually seen by a physician who had started her on insulin and told her, if you stop insulin, you will die. She had been started on 3 times insulin per day. Now, the parents were all upset, young girl, unmarried, 16 years old. So they came to us for a second opinion. They said, can you, check? Many people come for a second opinion, third opinion, they'll come. So we said, okay, we'll study the case and we'll tell you. We can't tell you anything, let's study. Now, the first thing we do in our center is not genomics straight away. The first thing that we do is to do a family history tree. This is called a pedigree chart. Now, this any of you can do. You don't need any genomics lab to do that. Take a pencil, take a paper or a pen and paper and start drawing. So this is the girl who came. Okay, she had one sister. Okay, she was 16 years old. When we took the family history, we found a mother had diabetes, father didn't have diabetes. Okay, then when we drew the father's side, we found the red here means diabetes. So when you looked at the reds, there were a few reds on the father's side, but if you look carefully, you will find now that is a father's brother. He's not diabetic. Father's sister, not diabetic. They are married into a family. Okay, none of the father's brothers or sisters, he had 3 sisters and 2 brothers, I think. None of them had diabetes, including the father. Okay, now look at the mother's side. If you look at the mother's side, now that is a mother's sister. She has diabetes. Okay, she had 2 children, of which one has already diabetes. Now, this sister is not diabetic. Then there's another sister here who has diabetes. Okay, another sister who has diabetes and another sister who has diabetes. So 3 of her 4 sisters of this mother are having diabetes. Now, if you go to the next generation, you will find that both their parents had diabetes. Father had, mother had, they had died. And we go to the next generation, the father's parents did not have, but this grandmother's father also had diabetes. So great grandfather had, grandmother had, mother had, and several of the aunts had, and one of her cousins has also got it. He was also around 16 and he also had it. So when we saw this family history, now this takes how long? 10 minutes, 15 minutes, you can draw this whole thing. So when they come to see us with the thing, the dietitian has already drawn all this. So we looked at this, we said, this looks interesting. We don't normally see this in type 1, although it can. Type 1, you can get family. With all this, she could be still type 1. Okay. So I said, but this looks interesting. First, hope that there's something coming from the mother's side. So it's worth seeing. Then, of course, the clinical investigations come. When the investigations come in, the first thing we do is C-peptide. We get the C-peptide results in 2 hours time. Okay, fasting and PP C-peptide. When the patient comes in, the HbA1c and the sugar results, C-peptide is ready in our lab. We have a very fast system to get the C-peptide. She had good C-peptide. Okay, fairly good, that is, like in a MODY. So we said, okay, this doesn't look like type 1 now. Family is there. C-peptide is good. So this is not looking like MODY. Then we do 2 other tests, GAD antibody test, zinc transporter. Only 2 antibodies we do routinely at our center. Both came negative. Then that doesn't come on the same day. It will come after a week. So we got it. When you got it, both came negative. So I said, now what are we dealing with? 16-year-old girl, mother is diabetic, aunts are diabetic, grandmother is diabetic, great-grandfather is diabetic, her C-peptide is good, GAD antibody is negative, zinc transporter is negative. What are we dealing? Is this really type 1 or something else? So we said, let's do MODY genetic testing. Okay, this is how we select cases for MODY genetic. We can't do genetic testing for everyone. It's too expensive. We just can't do it. Even if we were to do it free also, we won't have the money. And for everybody to pay for genetic testing also, it's not cost effective. So we said, okay, this child needs genetic testing. So we went ahead and did the genetic testing. Those days, it used to take months to get a genetic testing. Today, we can get it in 3 weeks' time. Okay, so we did the genetic testing. What we found was that there was an arginine to histidine mutation in the MODY 3, okay, which is the HNF1 alpha. So in the MODY 3, we found this particular mutation in this girl. Now, when I showed you the earlier slide, I told you her sister was not diabetic, isn't it? It took a few months to get the results. By the time we communicated the results to the family, they said, you know what, her sister has also developed diabetes. So I said, okay, let's take her sister's blood and then check whether she has a mutation. She also had the mutation. We checked the mother had the mutation. Then we checked all they went to the entire family, collected the entire father's family, entire mother's family, tested them all for all those who had diabetes, we tested for the mutation. What we found was these in-laws who are married, they didn't have the mutation. Whereas these people, her mother's sister, and these people are of course dead, but the mother's sisters who had diabetes, they had the mutation. Okay, I think finally about 8 of them or something had that mutation. Interestingly, that little fellow, the cousin of this lady, this girl, he also had the mutation. Okay, so it is very clear that now we are dealing with MODY, we are dealing with MODY 3, and this mutation was a novel mutation, not described. First time in India we picked it up. And we found it in 8 members of the family. All of them were behaving in a very similar manner. And so we published this in JCEM, Journal of Clinical Endocrinology Metabolism. Subsequently, we did functional studies on this and proved that it is really a mutation. We are one of the few labs which does not only the clinical work, not only the epidemiological work, not only the family studies, not only the genetic studies, but also we do the genetic mutation studies. We also do the functional genomic studies. So we can actually look at how the protein is expressed and all that we do in our labs, and Dr. Radha and her team do that. So we were able to prove that this is really a MODY 3. Now, MODY 3 responds to sulfonylureas. Okay. So we told her, look, we have good news for you. We'll take you off insulin. Okay. So we started her on sulfonylurea. Glibenclamide is sulfonylurea used. Now we are doing a trial of glycoside also. So we put her on glibenclamide. She responded beautifully. Okay. So the HbA1c came down to 6.8. She's not responding very well to insulin. Now the HbA1c came down to 6.8. Now it's about 15 years, I think, since we have seen this family. She and her sister are still responding to sulfonylurea after several years. Now to this particular, so this is an example of how MODY genetic testing helps to avoid unnecessary lifelong insulin therapy. Now imagine if this girl had not come to us and had not gone through all this, she'll be still taking 4 times insulin per day because of the wrong diagnosis of type 1. Now, is this common only in India? All over the world, about 80 to 90% of the monogenic diabetes like MODY 3 and MODY 1 are treated as type 1 diabetes, because people don't know about MODY, they don't know about genetic testing, and how many thousands of children. We have worked out that in India there must be at least some 20-30,000, if not more, children with this MODY who are going on with insulin lifelong, wrongly treated. Just imagine, her life completely changes. She's an unmarried girl, and putting her on a tablet and getting her sugar under control is very different from taking 3-4 injections per day. Imagine when she goes through pregnancy and other kind of situations. So this is a classical example of precision diabetes. And we are doing all this not for academic purposes, but because we believe we change the lives of people with this. Now, if you, and we have published, of course, extensively. That's our MODY 3 paper. That's our MODY 1 paper. We have published separate paper on clinical genetics on MODY 1. Then we published on MODY 2. Then we published on MODY 5. We've got several publications coming. We have discovered a new MODY gene, by the way, and that has been published separately. And now some functional work also we have published. So we are continuously working on MODY. But if you thought that that was exciting, MODY, how the lives of children have changed, wait till you hear about the next one. This is much more interesting. This is neonatal diabetes. Now, what is neonatal diabetes? It is diabetes diagnosed below 6 months of age. 6 months. That means newborn baby, just born, 2 months, 3 months, gets diabetes. And straight away for a newborn child, what will you say? Oh, this is type 1 diabetes. And then start. Let me tell you a clinical pearl now. Type 1 diabetes below 6 months of age is very unusual. Very, very unusual. Think again. If you get somebody below 6 months of age, think again. You may get 1 in a million, you may get, but most likely it is neonatal diabetes. And if it's neonatal diabetes, the treatment is mostly not insulin, it is tablets. And I'll show you about that. Now, so neonatal diabetes below 6 months of age. There are 2 types of neonatal diabetes. One is called the transient variety, the transient neonatal diabetes, which comes at 3 months, 4 months, but before the first birthday, it will go off. Okay, sometimes it will come back in adolescence or adulthood. But the second variety is what we are seeing commonly. This transient variety, the TNDM, doesn't come to us. We had only 2 cases. Whereas a permanent neonatal diabetes, PNDM, comes before 6 months and it will stay. Okay, and I would appeal to you, make an appeal in the whole of Kerala. And if there are any children below 6 months of age, please identify them and send them to us. Maybe we can take those, some of those children at least can be taken off insulin, and I'll show you that. Now, let me show you the example of this particular child case study, where a 72-day-old, not 72-month-old, 72 days, just more than 2 months old, 2.5 months old, female baby child came from Calcutta, and she was diagnosed to have diabetes 15 days after birth. Only 15 days later. First about 40-50 days she went about in Calcutta. They started her on insulin, told her it's type 1 diabetes. Then somebody told her that you go to Chennai, maybe they will be able to do some genetic studies. So she came. At that time, she was taking 14 units of insulin, small units of insulin. 4 times a day she was injecting. Imagine this 72-day-old child taking 4 injections per day. And that's the time when she came to us. So for us, there is a standard rule. Unlike MODY, any child below 6 months need genetic test. That is understood. The American Diabetes Association is saying any child below 6 months of age, mandatory. You have to do genetic testing, no doubt about it. Okay. So just because she's below 6 months of age, we said we'll send her for genetic testing. Okay. When we did the genetic testing, we found there are 2 genes, the KCNJ11 gene and the ABCC8 gene. These 2, if you have a mutation, they respond to sulfonylurea. But there are other types. There's a GATA gene and there's an insulin gene. And if you have those mutations, they don't respond to the sulfonylurea. They will need insulin. So because why I'm telling you this is, every child below 6 months, this is neonatal diabetes, stop insulin, try, don't do that. Because if it is a insulin requiring neonatal diabetes, child will die. Okay, so that is why without precision diabetes, you cannot proceed. You definitely have to do the genetic testing. It's mandatory. Okay, so we found this particular mutation, but this particular mutation responds to sulfonylureas. Okay, so that is a good news. Patient was still in our hospital when we got the results of the mutation. We got it fast track and we got it. Now what we did was we took the child off insulin, slowly reduced the dose of the insulin, introduce glibenclamide, very small doses, and then the insulin dose is gradually decreased. You can see what's happening here. Okay. Now, this is the sulfonylurea dose. So we started low, and then slowly we increased the dose of the sulfonylurea. That's the insulin dose. Okay. So the insulin dose is shown here. Okay. So the insulin dose was now first was around 12-14 units. From there, it came down, then became 0. By day 4th day, insulin is completely stopped. And what happened to the glucose level? That's in blue. Look at when the insulin was being given, high doses, you can say 12 units for a child, 14 units is quite high for a newborn baby. With that, that was the blood sugar level. Okay. Now, slowly the dose of the sulfonylurea is going up there, and you can see the blood sugars are dropping. This is 100. This is 100 blood sugar. The blood sugars have come to 100 now. Okay. Insulin gone, sulfonylurea is increased, and that's a blood sugar. It's a dramatic thing. You can't believe how dramatic it is. Okay. And so it completely changes the way the family, and for the family, it's a miracle. Somebody has told them 3 times lifelong. Now we are saying no insulin, switch over to this tablet, and then we are able to do this. And this is not pseudoscience. This is not, fiction. There's actual cases which are being demonstrated. And that is why I wanted to talk about precision diabetes, because you should know that such things are happening in our country. By day 5, there it is. She was able to completely stop her insulin there, and her blood sugars are completely normal, and her general condition also improved. No, some of these children with neonatal diabetes also have fits. They have neurological problems, because these receptors in other places also, the sulfonylurea goes and helps them. And so they have epilepsy, mental retardation, all kinds of neurological problems. That also can respond when you give the sulfonylurea. Okay. And I'm only talking about one monogenic. There are other monogenic forms of diabetes, thiamine responsive megaloblastic anemia, where the megaloblastic anemia also goes up, diabetes also goes up, just by giving thiamine. Okay. Vitamin B complex. If you give that, they respond. But only in that TRMA, thiamine responsive megaloblastic, only they will respond. And we've got cases of that also. When you do the genetic testing, you'll know this is a TRMA. This is a neonatal diabetes. There are also genetic syndromes. As you start screening them, you will find they have, Walcott-Rollison syndrome. They have a liver problem. They've got kidney problem. They've got, skeletal problem. Those children die. They don't live beyond, say, 15 or 16 years of age. They never reach adulthood. Before that, they'll die. You'll be thinking that they are normal type 1 diabetic, but actually it's a WRS syndrome, Walcott-Rollison syndrome. Okay, so you know the prognosis by doing this. So this keeps on adding more and more knowledge once you go into the precision diabetes stage. So we have been publishing a lot on this. This is one of our first reports in 2012, where we characterized the neonatal diabetes and monogenic diabetes in Indian children. We have had many other publications subsequently. Now, this is just to show you how, and Radha has now got about 30 or 40 such cases now, the first 7 cases, where you can see the HbA1c levels before sulfonylurea treatment with the insulin. All the A1C 16, 10, 11. After sulfonylurea 7, 5.9, 6, 7, 7, 6, 6. And you can see the fasting blood sugars, how it has come down to normal levels after starting sulfonylurea. It's very dramatic kind of a thing. Now, that's a total number of the neonatal diabetes registry. We have a registry at our center. It's not a rare thing. We have 435 cases. Can you imagine? 435 cases have already come to us. And from Kerala itself, we are getting a lot of referrals and accurate diagnosis. And Dr. Raghupati, whom Dr. Finney may know well, he was earlier in CMC, used to refer from there. Now he's in Manipal Hospital in Bangalore. He refers a lot of patients. Institute of Child Health from EGMO, a government hospital, they refer a lot to us. All India Institute refers, Delhi refers to us. And we do it free. We don't charge for the children, because we think it's not ethical to say you pay 2,000 rupees, 3,000 rupees, child can't afford. He said it's free. It's on me. We're doing it as a service to the nation. So we don't charge anything, and we do that. How many children have been referred? 265. Okay, of which 248 had the permanent neonatal, and the majority of them had, luckily, KCNJ and ABCC8. These two respond. Number 1 and number 2 is this, and both of them respond to sulfonylurea. If rarely we get an insulin gene, they won't respond. So we can say continue your insulin, but that's rare. So luckily these two are. Now these are genetic syndrome. We have 41 of them. Okay, and all kinds of DID mode, TRMA, which I told you, thiamine responsive, and also Walcott-Rollison syndrome, and many other syndromes are also picked up. When you do the genetic testing, at that time the child may not have the features of genetic syndrome, but then we can start, once you identify it, you can start looking, you'll find the child is short, bone is affected, this is affected, that is, these are poor prognosis. Many of them are poor prognosis. The last point I want to talk about is there is an opposite condition which we are seeing increasingly now. That is the opposite of neonatal diabetes. It is neonatal hypoglycemia. It's called congenital hypoglycemia. From the day of birth, the child has hypoglycemia. First, you'll think, oh, mother had GDM and they gave insulin. It's not all that. They give glucose, they give something, blood sugar will be 20. Child gets fits. Hypo goes on and on and on and on. Now they started referring for genetic testing. We've got 129 cases of this. And so they're also very interesting. See, it's a KCNJ there and the ABCC8 there. Same KCNJ, same ABCC8, same insulin gene. The gene is the same. So why does one produce hypoglycemia, the other produce hyperglycemia? It's a gain of function mutation or a loss of function mutation. So if you have one, you will get diabetes. If you have the other mutation, you will get hypoglycemia. Okay. Now, what is the advantage of knowing this? Now, through this, these 129 cases, depending on the mutation, you will know who will respond to diazoxide. The treatment for that is diazoxide. So diazoxide will only respond if you have certain mutations. In the KCNJ, ABCC8, if you have a set of 4 or 5 mutations, you will respond to diazoxide. There are some who will not respond to diazoxide. They will die unless you do subtotal pancreatectomy. Now you can imagine removing the pancreas of a child, almost 80–90% of it, to make that child live. Before you do that, wouldn't you do a simple genetic test, which you can get in free of cost, done? Now we're doing it free for you, and you find out whether it should be diazoxide responsive or not, and then you can go for your subtotal pancreatectomy rather than taking every child and removing the pancreas. So I mean, this is where precision medicine is heading, and right now on Monday, Radha making the presentation, she's got, these are old statistics. We've got much more now. This year we've picked up so many cases, particularly hypoglycemia. We're getting more and more cases. And 1 or 2 have been so fascinating that this hypoglycemia, after being treated for years and years, 5–8 years, suddenly they become diabetic now. Because the gain of function mutation changes into loss of function mutation, and then they become diabetic, and now they need treatment now. But they'll respond to sulfonylurea. So see how the field is getting very interesting. It's complicated, but once you understand it, it's very simple. It's a specialized knowledge. What we're saying is make use of us, and let India benefit by getting. And you since you have now listened to this talk, you spread the word around, and then contact all the neonatologists in Kerala. Kerala is a very educated place, literate place. You spread the word around and connect us to all the people who neonatologists, and when they check a blood sugar and they find it's high or low, just put them in touch with us, and then we can help to build up this national resource. So I mean, it makes big news. Genetic testing helps to treat diabetic infant, 3-month-old treated for diabetic. Doctors say ignorance about disease is widespread, and so on. It's still not reached enough. I keep telling Radha, for all the work we have done, nobody even knows you're doing this. Still sending blood to Exeter in UK. Nobody even knows about it. So I was telling, how do you make people know about this? So that's why when Jacob called, I said, okay, one more place, let us go and talk about this topic. At least some people in Kerala will know that such facilities are available. Okay, so I'm going to stop here by saying that precision diabetes is slowly coming of age. I won't say it has reached a stage where everything is precision diabetes. Far from it. These are still baby steps only, and all over the world, I think in the same, whatever the rest of the world is doing, we also do. We are not behind in any way, but we are not ahead also in any way. We are all in the 3 or 4 big centers which work on it. We are one of them. Comes of age, it can be applied to all forms of diabetes. With respect to type 2 diabetes, 4 clusters have been, I told you. SID and MOD, same as Scandinavia. 2, IROD and SERD is different. Then study of monogenic diabetes has helped many children with neonatal diabetes and youth with MODY to go off insulin. And precision diabetes can help to offer precision treatment and thus improve the quality of life. Before I end, I'd like to, of course, that's Radha, who's there, and this is her big team, Kantimati and Bodhini and the whole team here who work, Liju Samuel and Gopi, and many of them have done their PhDs on this. So lots of papers have come out from this team, 100 publications, can you imagine, from this team, and 13 PhDs have come out from this department, very active department. And the other thing that I want to tell you about is we have our update, which is coming. And in this update, we have the world leaders. They have put precision medicine right on top. And I think for the first time in India, we are getting the world leaders in precision medicine to talk to us. So one is talking in precision type 1 diabetes, one is for precision type 2 diabetes, the other is talking on GDM precision diabetes, and we are going to talk on the Indian experience, where some of the new data will also be presented. Much exciting, much more exciting than what I presented today. So we are going to do that, and that's on 30th, 31st of July and the 1st of August. That's the last weekend. And to register, you just go to Dr. Mohan's diabetesupdate.in. I want all of you to register and be benefited from that. We have both morning session and evening session on Saturday and Friday and Saturday. Sunday, we have only the morning session. So it's 2.5 days packed programs with all kinds of topics, including the latest insulin pump which is going to come. That is going to be, thing, insulin from diabetic foot to diabetic eye to, you name it, advanced technologies to everything, including latest research in India, obviously, will all be presented. So the other thing I want to tell you is that tomorrow we have our a very special meeting, to me, very historically, very important meeting. We are presenting tomorrow at 6 o'clock. Now it's 6, it would have just started tomorrow this time. We are presenting what's called as the Victory Over Diabetes Awards. And it's very relevant to what I'm talking today, because we have identified people in India who have lived for 60 and one for 70 years, 70 and 60 years with type 1 diabetes, having got it as a child. Now they have lived, one man is 86 years old, he got it in his 16, he's 86 years old, okay? And never these people have been presented in India before. For the first time, I think, in Indian history, we are presenting these 6 people live and then awarding them the Dr. V. Mohan Gold Medal for conquering diabetes, Victory Over Diabetes Medal. And Dr. Jitendra Singh, the Minister, Union Minister, will be handing over he'll be present and he'll be handing over the medals to these people. And we have also all kinds of, the diabetes ambassadors being honored. It's a whole event is on type 1. Also, in that event, for the first 10 minutes of that, I'll be presenting the history of diabetes in pre-independent India. Nobody knows that. Nobody knows that. I've been in the field for 50 years. I didn't know it. And I discovered some real treasures of India. For example, who got insulin first in India? Today you will not know, tomorrow you will know. And I've written the article. It's been published in JAPI, this issue of the Journal of Association of Physicians. Already proof has come. It will come there. The Week magazine will probably publish it tomorrow. They said it will be out tomorrow. And tomorrow, day after tomorrow, it will be out. So look for the Week magazine. Outlook has published something today. It's hit the stands today. It's all on 100th year of insulin. Because July 1921 was when Banting and Best discovered insulin. We are now in July 2021. So exactly 100th year, almost to the week. And so it's a very exciting time. So I thought it's very appropriate to find out people who have lived 70 of those 100 years with insulin in India and to showcase them. And I'll now stop sharing, and I hope Jacob can put up in the chat box how to join that. There it is. So the Victory Over Harish Ravindran has put it up. And if you want, you can see in the chat box. That's a YouTube link and that's a Facebook link. You can take a picture of that and join tomorrow. Actually, on Facebook Live and YouTube Live, it will be telecast as the event is going on. It's live, and anybody wants to attend that, you can already registered for international update. Rajiv Ambat. Okay, thank you, Rajiv. So I'd like all of you to register for the update, and all of you, again, it's free. You don't have to pay for update registration or anything. And tomorrow's event also, please attend, because it's a once in a lifetime event for me, to an event like that tomorrow. So I'm very excited about it. I worked about 9 months to get all that data, the history, identifying people all over India, calling them for the award, and then giving them a medal and honoring them. The whole idea is to encourage youngsters with type 1 diabetes, newborn child. Even today, an 8-year-old child came and she was refusing insulin, saying that I don't want insulin. So I said, please attend the function tomorrow. And then you will see people like you who would have said 80 years ago, 70 years ago, and today are still alive and they're going on, And so you should, so she's promised she'll listen to that program. So that's the whole idea. sometime later, 2-3 months down the line, I want to organize a separate event on neonatal diabetes and MODY, and call everybody who's interested, and then tell them of some of the latest results. Some of them are really, really, exciting. So I would like to do that also, and we'll keep you informed about that. So I'll stop here, and if there is any questions, I'll be very happy to take. I think Philip, you will be moderating the questions. If there are any questions, please go ahead. Thank you.
Thank you. Thank you very much, Dr. Mohan, for that excellent talk. It was such a eye-opener in many ways to understand that diabetes is not such a depressing scenario, which many people feel. Today, a patient like you came to me and started crying because she's diagnosed with diabetes, and she felt the world has ended in a sense. So it took quite a bit of energy to get her that things are not over yet, and how we can even reverse diabetes we were talking. So I'm really encouraged by this talk. And while we wait for questions to come on the chat box, I don't see any question yet, but can I just ask you one question, Dr. Mohan, about looking at the various types of MODY we have in India, which is the commonest in your opinion? Previously, we thought it was MODY2, glucokinase, but I think in India, it's not that, right?
It may be still MODY2, but the problem is MODY2, not the problem. The fact is that MODY2 is such a mild disease. It is asymptomatic. Very rarely the HbA1c goes above 6.5, and usually it's 6.2, 6.3. It doesn't cross 7 at all. And so why would they go to a clinic in the first place? So they usually get picked up during screening for gestational diabetes. They'll find a slightly high sugar, then they'll put them on insulin, saying that you've got GDM, but it's not actually GDM. It's MODY2, glucokinase. So if you start screening the population, you will find probably glucokinase is the largest number. We have published one report on glucokinase gene, but that's a rare thing for us, because why would they get referred to a center like ours if they have no symptoms? HbA1c is less than 6.5. Why would they do genetic testing? And why would they? One or two thought of it, because it was so mild. They said, I think one Calcutta doctor told me, I think this is GCK. Can you look at it? And I said, you're absolutely right. And the whole family had GCK. So that is the thing. But among the MODYs which are symptomatic and which come, in the misdiagnosed as type 1 diabetes, by far the commonest is MODY3, that is HNF1 alpha, okay, followed by MODY1, which is HNF4 alpha. So these two both are HNF, and MODY3 is the commonest, and the second commonest is MODY1, and then comes probably MODY12. MODY5 also is quite common. MODY5, however, you will have kidney abnormalities, you'll have genitourinary abnormalities, you'll have congenital abnormalities of the kidney, you can have an absent kidney, agenesis kidney, horseshoe kidney, cysts in the kidney, all these, or even genitourinary abnormalities, uterus abnormalities, all these you'll pick up clinically and then think of MODY5, and those patients usually don't respond to tablets. They respond because some amount of pancreatic agenesis also takes place. So they need insulin. But the most satisfying is MODY3 and MODY1. Now, we have shown recently, and Radha has got unpublished data, which is going to present to ICMR, that MODY12 also responds equally, just like MODY3. Now, the UK group and all that refuted it. They said, no, it's not true. I said, okay, refute it. We are going to publish it. We are very convinced about it. And now we have got the data to actually prove it. So it's probably one of those Indian things that MODY12 also, and it responds just like MODY3. Beautiful it is. So these three I would put on top of the list. MODY2, GCK MODY is of course common, but doesn't need any treatment. You can leave them alone. And MODY5, if you have, there is MODY5, but as far as, and they can have MODY5, need not have diabetes at all. You can have just the genitourinary problems and the congenital abnormalities. And if they have diabetes, majority of them, they have a different gene mutation altogether. And then they need insulin. Usually they need, and that can have a deletion, a complete deletion of the gene or something like that, and or complete one copy being absent. Those kind of abnormalities are a little more than a single mutation as in a MODY3 or a MODY1.
Thank you.
Any other questions? Have any of you seen any neonatal or MODY or anything in your? You should talk to your pediatricians and start looking for it. You might find one or two cases, not that you're going to see hundreds of cases, but there is one doctor from Kerala, Dr. Chandini from Calicut, who refers a lot of cases to us. From Calicut, Dr. Radha, you're there, no? On the call? Dr. Radha, are you there on the call? I can see her name.
Yes, sir. Yes, sir.
Where is Dr. Chandini from? From Calicut, no?
Chandini is from Calicut.
Calicut. Okay.
Chandini is from Calicut. Yes.
Right.
Just trying to see whether I can get the name of the hospital.
Yeah. Okay.
Huh?
Any other questions?
Children.
In the government hospital.
It's a government hospital.
I think it's a medical college. She's a professor.
Chandini is from Government Medical College, Kozhikode.
Correct. That's right. She is in the Calicut Medical College. Yeah. Professor of medicine there and runs the diabetic clinic.
Can I just ask one more question?
Yeah, please. We have time.
So we have this group of young diabetics who come to us, and then we're always trying to figure out, is it type 1, is it type 2, is it early type 2, is it MODY? Then of course we think of FCPD, on which you have been published so much. You've been a section author on this particular area, I know. Is it worth making an effort to do an ultrasound and trying to find out FCPD before they get symptoms of steatoria or abdominal pain? Is it worth it, or should we not? Where would it come in the algorithm of a young diabetic evaluation?
It's routine for us. So we have a below 30 years onset. If you have below 30 years onset, we have, first of all, pedigree chart. Okay. So that if you have no family history, it's mostly type 1. Okay. Or FCPD. Whereas MODY will have the 3 generation, type 2 will have both parents having, it's compared to MODY where one parent is there in, like in this girl, whereas in type 2, you will have both parents having diabetes. Then easy thing to do is go down the family history first box. So no family history, most likely type 1. Strong families, both parents, most likely type 2. One parent having diabetes, most likely MODY. Now, a history of abdominal pain, recurrent abdominal pain, FCPD will straight away come there. All we need is simple X-ray of the abdomen. Just make them stand, take abdominal X-ray. The stones in FCPD are huge. They're not like some small, you have to search for it or something. There is alcoholic pancreatitis. Here in FCPD, either it's there or it's not there. You don't even need ultrasound. You know, X-ray is much better than ultrasound also. Sensitivity is more. Ultrasound, you need a proper person to look at the pancreas, dilated duct and all. Here, you don't need anything. Simply plain X-ray of the abdomen, you'll find the stone. So if you get that, FCPD, finished. It's over. Now, so if that is not there, FCPD is kind of ruled out. Of course, you can still do ultrasound. Sometimes they'll have dilated duct without stone. Those are rare. So that is no X-ray means no calfly, you ruled out FCPD. Next, now you come look for ketosis. If ketosis is present, it's most likely type 1. Ketosis absent, then it's MODY or type 2. Now we look for obesity. If you have obesity of acanthus nigricans, it is type 2. No obesity, no acanthus nigricans, MODY, most likely. Or a lean type 2, one of the SID variety or something. By the way, those SIDs don't have MODY. We have checked them for MODY. They are lean type 1. So that's a problem. In our country, we have got the lean type 1 having quite commonly coming there. So that's the differential diagnosis with MODY. And of course, the type 2s respond to metformin better. MODYs respond to sulfonylurea better. So if you, in that kind of a situation, if you have, you do the MODY genetic testing. Otherwise, you don't have to do MODY genetic testing in every type 2 who comes to us. So who should get the genetic testing, if you ask me? Number one, if you find anybody, any child below 6 months of age, any child below 6 months of age, straight away genetic testing. Because you'll have to find out whether it's neonatal or type 1. 99% it will be neonatal, 1% it will be type 1. Number two, you will find that whether it's PNDM or TNDM or what it is, and then within that, whether it's KCNJ or ABCC8, which will respond to sulfonylurea. If that is not there, insulin gene, then they will continue insulin, which is rare. Okay, so that pathway you can see anybody below 6 months of age. Whom will you do in a suspected type 1? When will you ask for the MODY testing? Okay, if you find a very atypical type 1, how is it atypical? GAD is negative, zinc transporter is negative. You measure C-peptide, some C-peptide is there. It shouldn't be there in a type 1. Okay, the HbA1c is not going very high. It's only 8, 9, 8.5. HbA1c will be 11, 12, 13 in a type 1. Blood sugars will be 400, 500. But blood sugar is only 250, 280, 300. Doesn't go more than 300 often. And they're very mild all the time. If you put an AGP, if you put the sensory patch, in a type 1, it'll be going like this. you will find it's going like that. Oh, this is not a type 1 pattern. Is this something else that you're dealing with? So there are many clues which will tell you that it's not a classical type. They never had ketosis. They didn't have decay anytime. Presentation was not, acute, and suddenly one day they had urination, they had this one, they had loss of weight, they had loss of thing, they started vomiting, blood sugar went very high, decay, they're admitted in hospital. That is type 1. MODY doesn't present like that. MODY is a slow genetic thing. So whereas you find somebody, we went somewhere, they picked up a 10-year-old, 12-year-old child, they picked up and they said had mild diabetes. By the way, mother and also has diabetes, father has diabetes, somebody has diabetes. Is this really type 1 or not? Then you do the antibody test, comes negative. ADA says if antibodies are negative, genetic testing, clean, very, very clean in that. So if antibodies are negative, you have to do genetic testing, because at least you can stop the insulin if that is there. Then if you have some other, of course, in all hypoglycemia, you have to do, because CHI, without that you cannot treat, whether it's diazoxide positive or not, that you have to do. Then number 4, if you have some other, history, for example, maternal deafness, mother has diabetes and the child has deafness, that is mid. Maternally inherited diabetes is deafness. Mother had it, child has it, child has deafness, that is mid. Okay. You have optic atrophy and you have diabetes insipidus and diabetes mellitus, that is did mode. Okay. So that's a different syndrome altogether. If you have anything unusual, type 1 having optic atrophy, type 1s don't develop optic atrophy. So it is some syndrome. What syndrome is it? Child is not growing properly. In spite of giving insulin, child is very stunted. Then there's skeletal abnormality. Then are we dealing with Walcott-Rolison syndrome? So like that, if you split it down, you will find that not everybody needs a genetic testing. There is a small group of people in whom you're not sure. Those cases, you get the genetic testing. Okay, there are no further questions. We can probably stop. Okay.
Yeah, I really want to say thank you, Dr. Mohan, for sparing your precious time to be with us. I'm sure many youngsters in this group who have benefited, and I'm sure you will get more referrals and more patients being sent over. Thank you so much.
Thank you. Thank you.
I want to hand over to Dr. Jacob to say closing comments.
Yeah, sure.
Thank you so much, Dr. Philip Finney and Dr. Mohan, sir. It's been a senior endocrinologist, Dr. Anulekha Mary John online.
Oh.
May I request Dr. Anulekha to say a few words?
Good evening, sir.
Good evening, Anulekha.
Hi. Sir, it was really, really encouraging to listen to you, and the way you have started. When you said that you read that paper in 1975, we can see how very academically oriented you were right from your very young age. That has paid off, and how very meticulously you have been looking after your patients. That's really encouraging, sir. Really hats off to you, sir. Thank you so much.
Thank you so much, Anulekha. Look for such cases. William Osler said that, treasure your exceptions. There may be exceptions. We are not saying that that's the rule. Nowhere I said that neonatal is the commonest form of diabetes. I have only 400 cases out of 5 lakh cases. But those 400 to me are very precious cases out of 5 lakh cases. But those 400 to me are very precious, because they are something which we can, every life we can change. And it's not in the numbers alone. It's not the common garden type. But when you're able to identify something different, you being an endocrinologist, you pick up a Hashimoto's or you pick up something else. And that is where the real, we are able to contribute something more to that particular patient than a GP or a physician who may not be able to go to that extent. If you have picked up a Cushing's, you have picked up something else, you picked up some rare thing, and now you're able to offer, which everybody thought is obesity, but you're saying, no, this is not obesity. I'm able to pick this up, and then do that. I think that's where our clinical skills have to be honed. And then once you do that, it's a real pleasure, because that's what, otherwise, what is diabetes? Such a dry subject, given sulfonylurea, given insulin. What more is there in your whole life? Can you imagine 50 years of my life just giving that insulin and sulfonylurea and living there? I would have quit long ago. I got totally bored. In fact, I didn't even want to do medicine because of that, as I've written in my book. But it's the research and that passion which keeps the interest going. In fact, when I finished my MD, I got the gold medal, and my boss, he kind of begged me. He said, Mohan, don't leave medicine. Please be with me in general medicine. Become a professor here, and your knowledge is good, so you can come. I said, sorry, sir. I took up medicine only to do diabetes research and to work on diabetes. oh, we are going to lose a good general medicine person. I said, yeah, maybe, but diabetology will gain 1%. So, and I took up medicine only for this. So now I cannot, after saying become professor of medicine and learn everything and I want to go deep into one. Maybe I'll know less and less of more and more. That's fine. Or more and more of less and less. So that is fine. But that's what I want to do. And that's what I feel I can make a niche area there. And so my life is set. I'm going to do this, I told him. And he said, yeah, with great regret, I'm leaving you and all. Then years later, he told me, I think you did the right decision, Pa. You made some mark somewhere. So I think I'm happy that you did it, he said.
Truly inspiring, sir. God bless you.
Thank you, Anleka. Thank you so much. So shall we sign off now, Jacob?
Yes. To all of you out there, thank you so much for coming in.
I think your voice is cracking because of bandwidth.
I just finished reading this. This is
I think
biography.
He's having a
I think Jake,
bandwidth problem. Yeah.
yeah.
So thank you so much. It's been an amazing read.
Now he's back. Yeah.
It's an amazing read, and I think
Okay.
I think you can tell him.
Thank you.
Okay.
Yeah. Thank you very much, Dr.
Yeah,
Mohan.
thank you.
It's
Thank
a
you.
pleasure having you with us. Thank you. Have a good evening. Thank
They
you.
were just telling me that.
We are losing you, Jacob.
Oh,
Bye. See you.
Bye, sir.
thank you, sir.
Bye bye.